let's have a discussion of a very relevant, that means from your examination point of view, and a very practical topic, that is complications of the fractures. Complications of the fracture can be immediate, could be early, or it could be a late or a delayed complication. And what we have kept as a set to be discussing is a complication which are avoidable. That means if you treat them particularly, then these hazardous complications could be avoided. All right. So the first complication is, before we talk about that complication, let's have a discussion on a sample question. All right. Now, what is being provided over here and what are the key terms that you should focus on? A patient with a fracture both bone right leg, that means tibia and fibula, both of them are fractured, admitted for surgery with above knee slab. So the patient is in IPD, inpatient department, having above knee slab, immobilized, kept in the IPD, waiting for surgery. So third day on rounds, the professor noted a swelling in the toes. So what he has noted is there is a more than normal or beyond normal kind of a swelling, which raises the suspicion in his mind. So what he did next was that on extension of the toes, patient experienced extreme or intense pain. That means there was excruciating pain, the pain beyond the nature of the disease. And what next you have to do? This is what the sample question is. So the topic that you might be aware of is the compartment syndrome. So first of all, before talking anything related to these subheadings, what is compartment syndrome? Imagine if this is a limb, all right, and this is a bone in that limb. If this bone is getting fractured, for example, then there will be a massive collection of the blood. If there is too much collection of the blood, it will compress all the structures which are present inside that compartment. Like it will lead to the compression of nerve, the arteries, the veins, but most importantly, the compression of muscles. And if the muscles, they are kept compressed for a long duration of time, that means beyond 6 hours duration, if there is a complete ischemic contraction of this muscle, it might result in irreversible damages. So that will lead to a established compartment syndrome. So hope you have understood what I am trying to say. So as far as the etiologies are concerned, you see there are two types of compression. One is internal, which is coming by a fracture or an injury. And the second one is external compression. That, for example, if you have applied a very tight cast onto the limb, it will lead to extrinsic compression of all the structures which are present inside that compartment. All right. So as far as the etiology of this compartment syndrome is concerned, it could be categorized into two. And the two types of injuries which might lead to this compartment syndrome is a internal compression or a external compression. Now, every time you get a question related to this external compression, there will be a hint provided to you in the form of a tight cast. All right. If you have applied a very tight cast, if you have applied a very tight splint or a bandage which is responsible for compressing that entire component of the limb, which is resulting in a compartment syndrome. And internal are because of the fractures, closed fractures. You see, if the fracture is open, now you are aware what is open fracture. If the fracture is open, then the possibility of compartment syndrome will decline. Because whatever the blood is getting collected inside that compartment, it is exposed to the external environment and it will move out of that limb. So open fracture, the possibility of compartment is not there or less. So what you have to write and remember at the same time, that compartment syndrome is a rare phenomena, is actually a rare phenomena in open fractures. I'm not saying that it cannot happen. There is always a possibility of open fractures, because if there is a puncture wound which is not leading massive exit of that blood which is getting accumulated. So it is not like that it cannot have compartment syndrome, but it is a rare phenomena to have compartment syndrome in open fractures. Now, as far as closed fractures which are responsible for causing this compartment syndrome are concerned, so the commonest of the cause for this compartment syndrome is a tibial diaphyseal fractures. All right. Worldwide, tibial diaphyseal fracture are considered to be the commonest cause for this compartment syndrome. Other causes are the proximal tibial fractures. Then, apart from this, there could be a femur fracture, because femur, if is fractured, it results in massive collection of the blood. All right. Then, fracture of both bones in the forearm. radius and ulna. If there is a closed fracture, then there is a fracture of distal radius. It might also result in compartment syndrome to that particular limb. Then the fracture in the supracondylar region of the humerus, and so on. Supracondylar humerus. So the list is incomplete, or the list is endless, because any fracture can lead to a compartment syndrome, but these are the commoner causes which might lead to a compartment syndrome. Even a soft tissue injury can result in a compartment syndrome if there is massive bleeding or massive compression of the structures which are present. So this is the etiology. The importance of etiology in any question related to compartment syndrome is the internal or external. And you already came to know that the open fractures are associated or could be associated with compartment, but it is a very rare phenomena. Next are the clinical features. Now, it is not very difficult to identify what the clinical features are going to be. Like, there will be extreme pain, there will be swelling, there will be tenderness, all right. There could be a presence of blebs also. If the subcutaneous vessels are also getting compressed, the skin is not getting adequate vascularity, it will result in a ischemic bleb on the skin. So blebs over skin, all right. And even it can lead to a pallor because of the compression of the blood vessel for that limb. It might result in a pallor. But all these clinical features are not specifically diagnostic for compartment syndrome. Rather, there is no such clinical feature which is diagnostic for compartment syndrome. One clinical feature which is significant or considered to be most identification of compartment syndrome is the pain on passive stretch. The pain on passive stretch is considered to be the most sensitive clinical feature for compartment syndrome. Just imagine, you see, if you passively stretch the fingers, if you passively stretch the toes, if the upper limb or the lower limb is in compartment respectively, it is considered to be the most sensitive clinical feature. Then some of you will argue that if there is a compression of the vascularity, so absent pulse or a pallor can also be considered to be a sensitive or a diagnostic clinical feature. You see, pallor or an absent pulse could be a feature of shock also. So it is not diagnostic for compartment. So these are the clinical features on the basis of which you will identify. So if you go through the question, the first thing would be provided in the form of etiology, and second thing are the clinical features. So when you sum both of them up, you will come with the diagnosis. Then the third one is the management. That if you see a patient who is probably landing up in compartment syndrome, then how will you manage the patient accordingly? So as far as the treatment of this compartment syndrome is concerned, it is fasciotomy. So if the compartment is under the compression, you incise the entire fascia. All right, fasciotomy in its entire length, so that whatever the blood which is getting accumulated inside, whatever the cause which is responsible for this compartment is moved out and all the structures are decompressed. But in order to have the favorable outcome of this fasciotomy, it has to be performed within 6 hours from injury. All right. So in order to have the best possible outcome, it has to be within 6 hours of injury. So this is for the case where we are having or we are considering an internal bleed. In case a patient who is having an external cast which is applied and possibly the limb is going into compartment, then you have to remove the cast. That is the sensible management for the compartment syndrome. So fasciotomy has to be performed within 6 hours or as early as possible. But what if you are performing late fasciotomy? For example, by putting a star, you just try to understand that why the late fasciotomies are avoided. The late fasciotomies are basically avoided in order to prevent the vicious cycle. Just try to understand or imagine a situation where the limb is in compartment. This is the limb which is under compartment syndrome. It is because of the massive collection of the blood. And secondly, it will lead to the occlusion of the arteries and veins. It will result in the avascularity of that compartment. Now, if you perform fasciotomy within 6 hours, when there is irreversible damage to the muscle has not happened, then there will be a revascularization. And that revascularization will be responsible for decompression. It will be responsible for a healthy, reversible reversal of the damages which might have occurred to the muscle. But if you delay the fasciotomy, or if you perform it, for example, after 1 day, then what will happen? That already irreversibly necrosed muscle will be getting more inflammation by the revascularization, and that revascularization in a dead muscle will result in more necrosis. All right, so this will be causing a vicious cycle. So more damage will be happening, or you are encouraging more damage to the bone or more damage to the limb when you are performing a late fasciotomy. That is the reason why late fasciotomies are avoided. It is not considered to be the management. So majority of the time, it is just on the basis of the common sense you have to decide that what you have to go in the form of the management for that compartment syndrome. So as far as the questions are concerned, first thing, they will ask you to identify what is compartment syndrome. All right. And second thing, they will ask you the common sense management for that particular situation which is being provided to you in the question. Next comes the indications of fasciotomy. You see, although it is considered to be of a theoretical importance, that what are the indications which are used while performing a fasciotomy. So there are two theoretical indications. You just remember theoretical indications. The reason why I am asking you to write down the theoretical indications, because it is never used in the management as far as practicality is concerned. You are not going to measure the intracompartmental pressure before performing fasciotomy in your hospitals or in any of your medical colleges. So these are just the theoretical indications. The two theoretical indications are, the first one is that if the intracompartmental pressure is more than 40 millimeters of Hg. So some of them they have mentioned 30 millimeters of Hg, some of them they have mentioned 40 millimeters of Hg. That is considered to be one. That if you measure the intercompartmental pressure by placing a probe which is having a digital monitor, if it is found to be more than 40 millimeter of Hg, that means the limb is under compartment, and perform the fasciotomy. All right. Another theoretical indication is that if the mean arterial pressure, or if the difference between mean arterial pressure and intracompartmental pressure, all right, is less than 40 millimeters of Hg. So this is another theoretical indication. Now, out of the two theoretical indications which I have provided, which one, none of the two is performed while performing fasciotomy in reality, but which one is better as far as the theoretical indications are concerned? Then the first indication that you have written obviously is the incorrect indication, and the second one is the correct indication. All right. Although you will find this much, this is written in majority of your books, but it is considered to be an incorrect indication. Why? The reason is, just imagine if the patient is a systemically hypotensive patient, all right, where the blood pressure or intracapillary pressure is less than normal, then even 30 millimeter of Hg intracompartmental pressure or even 25 millimeter of Hg intracompartmental pressure might be resulting in a compartment syndrome. And because once you have measured it to be 25, you will think that why to perform it, because it is not a compartment syndrome. That is why you cannot use the term 40 millimeters of Hg and apply universally in all the individuals. There are systemic changes, and that has to be taken into account. That is why this indication is incorrect. Second is that what you are doing actually, you are measuring the main arterial pressure of the patient, and you are comparing it with the intracompartmental pressure for that same patient. And when the difference is found to be less than 40 millimeters of Hg, it means that the intracompartmental pressure is reaching towards the mean arterial pressure. Then it is considered as an indication to perform fasciotomy. So now you have understood that which one is a better indication. But you know, if somebody asks you that which of the following is the best indication for performing fasciotomy, so answer for that question is, by putting a star, you have to write it down, that the best indication for performing fasciotomy is